Miss Emmeline, is this baby 1 or 2 for you? 2. Baby number 2. You know what you're getting?
A girl.
A girl. You know, they always cause the most trouble.
Yeah.
Once you get that blood pressure cuff on you, I want you to put your elbows in your lap. Good. Now drop a big deep breath in. Blow it out. Good. Drop your shoulders down. Put your chin on your chest. Wrap yourself right around your baby, right around your belly there. Now I'm going to touch you with my cold hands. I do apologize for that.
Drop those shoulders.
Nurse anesthetists, like all nurses, care about their patients.
What I love about being a CRNA is the autonomy and working with patients and being able to care for them from start to finish.
They're not just thinking about how important it is for them to do their work competently and to carry out the procedure exactly as it's supposed to be carried out, but they're thinking about that individual person.
Most patients, when they come in, they say the scariest part is the anesthesia. And when we're able to come in and talk to them, and we talk to them about anesthetic options and what we're going to do and how we're going to meet them on the day of surgery, and just seeing that relief in their eyes, especially when they show up on surgery day and they see that same person they talked to in the pre-op clinic, they're like, oh, a familiar face, somebody that I trust and I believe in.
And it really has helped me to see how much pain changes people. And then when you can relieve that pain, it's really rewarding.
Try not to pull away. It does cause another poke. 1, 2, 3.
At the end of their procedure, when you're waking them up and they give you that look when they first wake up, they say, we're done? It's over? It's like, yeah, it's done. It's just that easy.
They're comfortable and happy, and I'm happy. That is a success for me.
And sometimes the only thing that gets rid of that pushing pain is pushing.
Right.
Okay? Do you have any questions for me? Pour yourself some medicine. I want you to call Gail and tell her you're going to do that, okay? Because it can drop your blood pressure just like...
We're a category of advanced practice nurse, and sometimes I think because we're behind closed doors, people really don't understand what goes on in an operating room. And so to say to them, well, if you've heard of certified nurse midwives or nurse practitioners, those are nurses that have gone for additional education and preparation to become an advanced practice nurse. And so I let them know that I'm like a nurse practitioner in terms of having gone for additional training, but that my additional education and skill preparation was in anesthesia.
I figured out there was a lot more to it than just standing at the head of the bed. You're managing their blood pressure, their heart rate, their breathing. You're basically keeping the patient alive and well. You're the only one taking care of the whole patient during a surgery.
Nurses have been doing anesthesia for many, many years. And in fact, there's some anecdotal and some documentation of nurses doing anesthesia during the Civil War. In that same time frame, Civil War and post-Civil War, there started developing nurses understanding that anesthesia is a specialty in and of itself, that you don't just grab an extra doctor or an extra nurse, that these people, some of the pioneers in nurse anesthesia, they were the ones that developed open drop ether. And then they said, well, we really could educate nurses to do this.
The first formal program to educate nurse anesthetists was started in 1909. The larger hospitals in the East, particularly the Cleveland Clinic, formed one of the well-known schools and educated some very fine people under the direction of Dr. Kreil, who was a surgeon who became very interested in anesthesia technique. And his primary anesthetist, Agatha Hodgkins, became the founding member of what became the American Association of Nurse Anesthetists. Dr. Kreil and Agatha Hodgkins and some of their other nurses actually went to Europe during the early part of the First World War with the Red Cross to provide services, and we're well known for the excellent care and the lives they saved over there.
Nurse anesthetists have been giving anesthesia for 150 years. It was a nurse anesthetist who worked at Mayo Clinic The Mayo brothers found the brightest nurse they could in the hospital and brought her down to the operating room where previously surgery residents were giving anesthesia, but they were really more interested in the surgery and not paying full attention to the patients. So Alice McGaw was brought down and she was taught how to give anesthesia. When one of the Mayo brothers needed surgery, one Mayo brother operated and the CRNA, Alice McGaw, gave the anesthesia. They set up a showcase of anesthetics, 14,000 anesthetics without a fatality. People came from all over the world to see them give anesthesia at the Mayo Clinic.
In 1948, it was reported that 75% of all anesthetics were provided by nurse anesthetists. Nurses were part of the field people in the Korean conflict, and they provided most of the anesthesia.
A nurse prepared and administered the anesthetic and watched you constantly for any telltale change in your breathing or blood pressure, all working with the same purpose: to ease the pain of war, to help save lives.
I was in the Army for 20 years. It's a very autonomous practice, both as a nurse or a critical care nurse or a nurse anesthetist, and I think that that's a big draw for nurses in the military.
There's a whole different world in terms of being a CRNA, especially in the military, because, when you think about being a CRNA, you think about being in a hospital in a, stable, controlled environment. But then when you throw the military aspect into it, you're talking about being in, somewhat not so secure locations. A lot of times you're not in a hardened facility. A lot of times you're working out of a bag on the ground. For me, in my last deployment, I was working in the back of a helicopter. And so, trying to manage patients and even do any type of anesthesia in the back of a helicopter can be a challenge in of itself, especially when, bullets are flying and, they're doing tactical maneuvers. They could manage these patients, they could handle a critical trauma patient, as well as, once we're stateside or even once we're back to our home station, because a lot of times these hospitals are in conjunction with these aircrafts. So once we come back, it's not uncommon that I would fly a patient in and then take them to the OR and do their anesthetic. You were that Swiss Army knife, you were that jack of all trades. You could do a number of different things. When you're out there, you're it. So there is no, there's not a partner with you. There's not a anesthesiologist there, to bring it to the forefront. You are the tip of the spear.
The very first anesthesia nurse in Colorado was a Sister Mary Gonzaga, and she came through the Sisters of Charity and was assigned to be the trained anesthetist at St. Joe's Hospital in 1896. And as far as we know, she was the first educated anesthesia provider in Colorado. So we go back many, many, many years. Education, as time went by, of course, became more formal. And in 1954, that was the first time that the certification program started for nurse anesthetists.
The scope of practice has changed immensely. Regional anesthesia is now part of the curriculum. The ability to work independently as advanced practice nurses everywhere have gained that. The ability to bill insurance companies. Educational programs have gotten more sophisticated. People are better prepared. They say that the educational program for a nurse anesthetist today is a master's degree, and that name just simplifies it too much. It is one of the most demanding graduate programs anybody can imagine.
We get patients at their absolute worst. They're scared. They've not had anything to eat or drink. Maybe the family who was supposed to bring them didn't come. Maybe they had an argument with their spouse last night or this morning or someone else. So a lot of times, and then we get them and we're poking them with needles and we're hooking them up to machines and we're telling them we're going to put medicine in your IV and you're going to go to sleep, we're going to put a tube in your throat, and then you're having surgery. So I think it is nursing at its core because we take those people and we comfort them first. We have to. Because if they're not comfortable with us, then how can we expect them to let us literally put them to sleep? To you, it's going to seem like no time. You're going to go to sleep, you're going to wake up, it's going to be done. Anything else? Okay, and I already asked you, are you warm enough?
I am warm enough.
Good. We'll probably fix that too. I'm gonna put this up. Okay. So we have to kind of develop that rapport fast. We have to be confident in what we do and reassuring in our nature. And I think that is nursing.
And how's your breathing feeling today?
It's great.
It's great.
It's been accurate recently. It's
Right, okay.
periodic and sometimes worse in
Right.
spring.
Right, okay, okay, super. Big, huge breakfast this morning?
Tiny sip.
Tiny sip, okay. And 137 over 82 this morning. Fantastic, good deal. So which knee is this here, Dr.
Left.
Myers? Left, okay, super, good deal, so cool. Okay, and then the vitamin D, the Flomax, and then the Pro Air and whatnot for your asthma. And, yep, okay, great. And then not allergic to anything at all?
No.
Very good. So, we'll do the spinal block back there, and I'll also put some preservative-free morphine in that spinal to help you with pain relief afterwards. Usually that's about 24 hours or so with that, okay? And then just keep you as sedated as you want to be in the operating room. So.
Okay, Bill told me when he had his, he spent most of his time talking to you.
Yeah, exactly, yeah.
And you had some interesting jokes.
You know.
He felt very entertained.
There you go. So cool. Yeah. So we can, I'll either sit there and we can chat the whole time while he's working on your knee, or if you want to be, sedated and sleepy, we can definitely do that too. So we'll just.
Any change in your heart history? Any new chest pain or shortness of breath? Anything like that?
Since I had the pacemaker put in.
Not since you had the pacemaker put in. Okay. Sometimes I just touch them. I'll hold their hand. I'll walk in and they're laying there with their IV and their blood pressure cuff. And if you just grab their hand, you just hold their hand, fuss with their blankets a little bit, that really comforts them.
We think of what we do as routine. We do it every single day, and it can become very routine. But we remember as nurses that these patients that are coming for anesthesia, it is anything but routine for them. It could be their very first encounter with us, 10 minutes of time of meeting us, and trusting us to deliver an anesthetic to them. So that nursing experience of being able to build relationships quickly has really benefited me in my practice as a CRNA. Okay, Ms. McDonald, we're all ready to take you back, okay? Are you good? Mm-hmm. All right. I'm going to start to give you some sedation. All right, that's going to start to make you feel kind of drowsy. If you don't remember the trip into the operating room, that's completely normal, okay? We're going to take great care of you, okay? No worries.
Thank you.
All right. I'm going to fix your pillow. You start to just think good thoughts, okay? Under a general anesthetic, of course, the patient's rendered unconscious, but serving as their advocate that entire time is really the role of the CRNA, not just managing hemodynamics and fluid status and pain status and depth of anesthesia, but really being their advocate. So speaking for them to the entire team, because sometimes the operating room is full of providers, of reps from different companies for equipment, and so serving as their constant advocate, speaking for them, making sure they're safe and comfortable the whole time is really what we do.
Tilt your chin up towards the ceiling, just a little bit. Perfect. Now take 3 or 4 real big, nice, deep breaths all the way in, all the way out.
Very tight on your left arm, okay? Just for a moment. Gonna check your blood pressure, all right? Everything's perfect. I know it's terribly uncomfortable just the first time. And then we're gonna give you a break, okay?
They taught us SAM Tide, and basically everybody still uses it today. So suction, airway, machine, tape, IV, drugs. And you go through that routine every single time when you're getting ready in the morning and before every case, so that you know you have everything ready to go. Oh. So we're still playing on M right now with machine.
We always say we have to be very obsessive compulsive. And I think that shows every time you watch a CRNA do anesthesia, because they have to have everything set up. They have to have their little nest made in the operating room so that they feel they have everything right where they can get to it on a moment's notice.
it's a constant assessment. You know, in nursing school, it's all about the assessment, be it the emotional assessment, the physical assessment, whatever that is. And that's what I feel that as a CRNA we have to do. It's an assessment of myself. It's an assessment of my equipment, of the patient, of the room equipment, maybe the lighting, the heating, the surgeon's beeper, the shoes that someone's wearing, whatever it is, it all has to be done.
CRNAs, nurse anesthetists, are there for the entire case, the entire procedure. We are there to put them asleep. We are there for the duration of the procedure, and we wake them up at the end, take them to recovery room, and then we do rounds later on and post-op all of our patients to see if they had any concerns or any problems with the anesthesia.
I'm gonna give you a little bit more pain medicine.
They do a great job taking care of my patients. It's a partnership and taking care of them, and I understand their abilities. I think they give a full spectrum of care to patients and are highly skilled and able to do what I need, that is to put patients to sleep and to take good care of them and wake them up and bring them successfully through an operation.
My association with any interest in the CRNA group was when I was president of the State Board of Health, where I served for over 8 years. Early in my term, the question came up about having non-supervision of CRNAs. And I was somewhat against that idea because I felt like several board members felt like the CRNAs might overstep their purview and do pain management and so on. Since that time, I've gone 180 degrees in the opposite direction. I think the CRNAs we have at this hospital are providing the best anesthesia I have ever seen.
The signs and symptoms that I want you to tell me. Ringing in your ears, numbness around your mouth, or tingling around your mouth, okay? Funny taste in your mouth, like a metallic taste. I'm just gonna slip this right through here. Just lets me watch you a little bit closer, but if it tickles you or irritates you, you just let me know, okay? So I have a little bit of sleepy medicine going through there, but we'll just go real slow, okay? So here in a minute, he's gonna test you. You may feel pressure, but if you feel anything sharp, that's what we wanna know about, okay? Okay, or if you're uncomfortable at all, just let me know.
Okay, can you feel this?
No.
No?
He says no.
Feeling good, huh?
Externally, I think people think that anesthesia is, oh, I meet the person and then they put me to sleep, they wake me up, and I really don't feel that's what anesthesia is about. I try and take the time to talk to my patients, to get to know them a little bit.
Just putting a little airway in there for you. Just because you're getting good and sleepy. You're doing real good. You pretty comfortable? Okay. All right, you're going to doze right back off.
The assessment of the total person, not just the physical, but the emotional, the spiritual, all aspects of a person relate to their health. It's not just, okay, the arm is broken, we fix the arm, makes everything better. No, because that arm is connected to a person who has to work and maybe can't work now or can't take care of their kids. So there's more dimensions to just fixing something, taking out a gallbladder, fixing a hernia. There are other aspects to people that I think are uniquely addressed by nursing that may not necessarily always be addressed by medical care.
So to be a nurse anesthetist, you need to have your BSN and work in an ICU at least 1 year. Most programs won't even consider acceptance into their program unless you have 3 to 5 years, because you really need that knowledge base to build upon. And then in anesthesia school, it's anywhere from 27 months to 36 months. And it's a very rigorous training, and you're training, doing the same cases side by side with the anesthesiologists, their residents. And after you successfully complete the program, you need to pass our accreditation exam before you can practice as a CRNA.
I went into it because I felt that I had never met a CRNA who regretted doing that. And so I went to anesthesia school and I loved it. It's like your own little mini ICU.
I think it's so exhilarating to be a part of the future nurse anesthetist training and educational process. I love watching them throughout their training process and see them master the science of anesthesia in the clinical setting. And I think I am so proud of the high caliber candidates that we always get on our clinical sites.
The doctorate program that I went through is a doctorate in nurse anesthesia practice. I think that all of nursing is moving towards doctoral preparation and advanced practice nursing. That just is one more step in providing the highest level of care that we can to our patients.
When you live in a community this small, you know everybody and everybody knows you. You go to the grocery store and the lady who checks you out, you did her anesthesia. Or you go to a restaurant for dinner and the lady who's waiting on you, you did her husband's anesthesia.
Rural communities have been very creative about the use of their workforce and to meet the needs of their community. So they have really looked at the types of resources that they can use to the full extent of their training and education to meet the needs of the community without busting the bank and trying to bring in provider types.
You know, about 80% of the land mass of Colorado is rural. 25% of the people live in the 55 sparsely populated counties, leaving 10 counties along the Front Range holding almost all of the people. So most of the state is rural, and we need to have affordable and accessible health care. Nurse anesthetists help provide that for us.
If we don't have the nurse anesthetists available to provide that service, these people wouldn't get care.
My name is Gary Cleaver. I'm a certified registered nurse anesthetist. I live in Fort Morgan, Colorado, and I've lived here since 1981. I travel around small rural hospitals that do not have their own anesthesia providers, and many times I am the only provider that goes to those hospitals. Many times I'm in 1, 2, or 3 hospitals in one day, possibly in 2 different states in the same day. Have you had any colds or anything like they have you? In the last
My
few?
nose has been running.
Nose is running, but your chest feels okay and you're not coughing. What I'm going to do is I'm going to give you some medicine in this IV right here, and it won't hurt. There's no more needle pokes. I'm going to wipe this with alcohol. Something I've found over the years is being in one area long enough and working these hospitals long enough, the patients become almost like a family. And the patients will call me at home and say, hey, I'm having a surgery. Are you going to be there? I will go to people's homes and go see them, like on the pain blocks for the back pains and things. They may have to use a county express type vehicle to get to the hospital, and they don't have access to come let me see them to follow up, so I'll go to their house and just check in on them.
You know, out in rural Colorado, our primary concerns are access to health care, and nurse anesthetists give us access to the critical care that we need. I mean, if you're injured in a farming accident and you need to have surgery, you need to have somebody that's there available in rural Colorado for you. And I know our nurse anesthetists out in eastern Colorado are there for us. Gary is there for us, and we trust them and we like them being part of our community.
They can manage a patient, stabilize a patient, even if they're critical. Using the whole spectrum of techniques, including intubation techniques, IV access techniques, pain management techniques.
The worst part is the stick and the burn when I put the numbing medicine. When I provide anesthesia, I am focusing on the particular patient that I'm about to provide the anesthetic for, what their health history is, what type of surgery we're going to be providing, what the risks are for blood loss or for hemodynamic changes within the surgical case that I need to be prepared for, what the risks are related to that patient's specific health history that I need to be prepared for during that case, and I need to have a plan A, plan B, plan C for any event that I could reasonably expect from a patient given their history and the surgical procedure that's occurring.
I'm Sherry Trahern. I'm the CEO at St. Thomas More Hospital. We're a 55-bed hospital located in Canyon City, Colorado. We're a rural facility. For facilities that are smaller, it is a very cost-effective way to provide the anesthetic services to our patients.
I think there's less redundancy of services too when you can utilize CRNAs as a full-service anesthesia provider in those institutions. At university, I know there are around 50 CRNAs, and they're going to work in all the areas. Sometimes anesthetics now are done in more remote areas of the hospital, in X-ray, in radiology, labs or suites, and that certainly is a big role for the CRNAs, not just in the main OR, in obstetric anesthesia and in analgesia. At University and Denver Health, both being huge places as far as getting a lot of cases for, the obstetric community. And so they work basically everywhere in the hospitals that anesthesia services are rendered.
I think having the holistic part of being a nurse is what makes nurse anesthesia such a special profession. When you walk up to your patient and they're terrified of having anesthesia, whether it be the first time or they had a bad experience last time, I think it's one of the most gratifying feelings to give them an excellent anesthetic, have them wake up in recovery room, and then them hold your hand and say, "Thank you so much." And that look that they give you, you did a nice job.
He had a grand total of 4 milligrams of Versed back there, a light propofol drip, spent most of the time chatting and snoozing. And I think that's about it. Excellent.
Yeah.
Adam, you feeling okay, sir?
I feel great, Scott.
Good deal.
This is
You get
sharp.
all the fun paid for.
All right.
And Justin is on call tonight.
Okay.
So if you need It's about patient care. I like dealing with patients. I like dealing with people. Let the nurses know.
I will. Thanks.
Okay.
Thanks again.
No problem.
Thank you
be
so
good.
much.
Okay. I'll see you later today.
Okay,
All right.
take care.
Super. Good. It's just nice to be able to help people, to work with the patients, and feel like I'm making a difference in people's lives.
I think the future of nurse anesthesia is very bright, and in light of the Affordable Care Act, we all know that there are a lot of patients that are going to be needing health care that now will have health insurance, will have a way into the hospital. And I think nurse anesthetists are poised to provide this service.
We're going to need to expand the scope of practice of nurse anesthetists and advanced practice nurses in general in order to meet the healthcare needs. And I think it's perfectly appropriate to expand that scope of practice as long as we have well-prepared, well-educated nurses who can provide that care safely and competently and caringly as well.
If I were still president of the Board of Health, I would have voted now to authorize them to do whatever they feel competent to do.
I love my job. I love it.
It's very rewarding.
I'm just in my element. I would never turn around and go back again.
It's the most wonderful position that you can have, that you get to take care of patients and take them through some of the most difficult times that they have in a safe manner.
Having that type of experience and that connection with patients has really, brought it to the forefront for me, and that's what I love about being able to have that hands-on and that close connection with patients.
We're basically their voice, their advocate the entire time they're asleep because they can't speak for themselves. So we're kind of their eyes and ears while the surgeon's performing on the other side of the drape.
It's rewarding both professionally and personally, and you can't ask for much more than that from a profession.
I think it's so comforting when I can say to a patient when I'm out there in the pre-op area before their surgery explaining what's going to happen. Hi, my name is Jennifer Herrenberg. I'm a nurse anesthetist. I'm going to be with you the whole time. You're in good hands. We'll take care of you today and everything's going to be okay.